All right. So announcements, these are again recorded. Y'all just got the, alert that this was being recorded. So if you want to go back and watch or have your friends want to watch, let us know. Free CME, of course, you'll get the thing at an email because you obviously had to register to get into this. So you'll get that. Attendance, if there are other people in your room, can you just please chat in other names? We just want to make sure that one, we have the right attendance because this has to get documented through like Echo World. And two, we want to make sure that everybody gets the CME that they're due for. Turn your video on if you can, because people are way better looking than boxes.
Yeah.
Even if you're eating,
we don't care.
That's okay. Case presentations. We really like case presentations. It's kind of part of the thing of Echo. Helps people learn, being able to learn from a patient. You always learn more when you see it. And so it can be hard, easy, just any kind of interesting case you had or a thing you have questions on, like, what do I do next with this patient? Let us know. There is a form, but you can even just type it de-identified in a Word document if that's easier. Upcoming, so in 2 weeks, we're going to go through how you prescribe to your first patient. So what does an induction look like? What does a micro induction look like? How do you, take that leap into, okay, I can prescribe buprenorphine, Suboxone. Now what do I do with it? 2 weeks after that, infectious disease complications of patients who use substances. And then after that, how does the emergency department play in? Coming up tomorrow on the other Echo, the Wednesday Echo, Dr. Charlie Resnikoff is talking about fentanyl test strips, and there's a bunch of case presentations he has with that on testing for fentanyl and what do you do when there's fentanyl involved. And then Wednesday next week, contingency management, which is technically the gold standard for medications or drugs like methamphetamines where there isn't a perfect MOUD. So how does that work?
I've actually seen that talk. I saw her give it that talk on their own Echo, and it was actually very good. So,
and they're in Alaska, so it was like midnight. No,
3 o'clock.
3 o'clock in the afternoon. The weekly Addiction Connection podcast, we did release a topic today. What was it?
On alcohol testing.
Alcohol testing. So kind of the guidelines for patients with alcohol use disorder, screening tools to be used in clinic, and then there's different lab tests to monitor and or screen if needed. We're going to release another one later this week on the whole controversy out right now about using marijuana/cannabis to treat or prevent COVID. So we dove deep in that one.
It's pretty interesting.
It's very interesting. If anyone's getting started or has questions or concerns or comments that you might want protocols or policies or paperwork or just help, especially with those first couple inductions. Oh, thank you, Christy. I was just going to say that too. I'm glad you wrote that in there. Please reach out to us at any time for anything. Those are our cell phone numbers. When Kurt starts talking, I can type in our email addresses for y'all as well. Objectives, I'm just going to jump through that and let you take over.
I guess she's going to let me talk. So what we're going to do today, this was going to be a talk that's just a little bit more about some of the treatment for the different MOUDs, different medications that we can use for opioid use disorder. And I did something that's just a little bit different because I also wanted to put in some of the historical stuff of the legislation that kind of led to all these things over the last 50 years, because really a lot has changed. Can you move that over just a little? I can't see the slides. So what we're going to do is kind of run through some of that stuff and talk a little bit about why we are where we are now. So MOUD treatment options. So again, 50 years we've been doing this, and policy has advanced a lot of things, and it's really improved kind of the recognition of opioid use disorder. I think it's played a pretty big role in standardizing kind of the practices of how we do this. And of course, a lot of these different acts that have come through Congress have kind of increased access. We'll talk about that. And of course, reimbursement, especially some of us can remember when Medicare was not covering methadone and some of these other things that really made a difference because we had a lot of patients with opioid use disorder in that age range.
And so really, when you look at the federal policies, a lot of these, promoted access and utilization of MAT. But really, if you think about what's gone on, there's been difficulty kind of keeping pace with kind of the opioid crisis. And so, to that point, if you look at kind of the numbers from really 2009 to 2019, the treatment facilities offering MOUD really were only increased by about 18%. And a lot of us have been doing, Suboxone for a while, know that it is often really difficult for us to get a treatment place that would actually treat them with buprenorphine. So that's been difficult. But actually during that same time, overdose deaths from opioids have increased by 130%. And remember, that's 2019. In 2022, as we all know, the numbers are skyrocketing and will be six figures this year. So it's really not gone well. But there's really been 5 kind of milestone acts. There's been a lot of smaller little things that have come through Congress over time. But there's 5 different things that we're going to talk about that have kind of impacted kind of that standard of care for OUD and really how addiction treatment policy runs. And as we all know, this is affecting hundreds of thousands, if not millions of people and their families. And so these things have really kind of changed things. These are the 5 different legislative things that have occurred at the national level. And I'm not going to go through each of these right here, but we're going to kind of just explain what each of these did for us. And I think it's important that we understand what it was like before we had any legislation for this. If you look way back at the Civil War, coming out of the Civil War, there was more than 300,000 people on chronic opioids by 1900. A lot of people from the injuries from the Civil War, the amputations, and these people came out basically using morphine, which was a common thing at the time, and opium. And it was not uncommon at that time for doctors to prescribe morphine, heroin, and even cocaine, sometimes to try and taper these patients or detoxify them. And often they were doing maintenance therapy to keep these people on their medications. And so I think that, that was kind of considered normal operating procedure back then. So things have really changed. So really the practice of prescribing opioids kind of as a treatment, I'm not touching a thing. We're not sure what's happening with our computer here. It's going crazy. But the practice of prescribing opioids as a treatment or to detoxify patients actually ended in 1919. And that's when the Harrison Narcotic Act of 1914 took place. Prior to that, you could treat people with an opioid use disorder with an opioid, and that was considered normal. And actually, in our world, we cannot even treat somebody in withdrawal with a full agonist opioid other than methadone. And of course, you have to have a special license for that. So understand that in some countries, for instance, Canada, you can actually give somebody an opioid that's in withdrawal, and that's considered okay, whereas in our country, it is not, specifically because of the Harrison Narcotic Act. And really the result of that act in 1919 was that they quit prescribing or dispensing any opioids for treating addiction, and there was really no treatment. So any type of use of that was completely prohibited. And at that point, really people with an opioid use disorder were basically thrown into the criminal justice system, okay? It was not considered a medical problem. And so things just went a whole different direction. So just to go in the weeds just a little bit, because this is so interesting.
Our favorite thing to do. Somebody else can.
So just a little bit in the weeds. So this is what happened after that act took place. So in 1919, you had no treatment basically for people with opioid use disorder. And so it took 10 years for the government to say, okay, there's something, we need to do something with this group of people. And why don't we start these narcotic farms where patients can go for treatment? And there was actually 2 of them that were funded by the federal government in 1929. And there were 2 ways for you to end up at the narcotic farm. One of them was you had a drug-related crime, and they felt that you had an addiction, and they would send you there. But it was also a place, just like any treatment center, that you could just check yourself in. And it was there were 2 different places. There was one in Lexington, Kentucky, and there was one in Fort Worth, Texas. And they were the only treatment options during that time, really from 1929 until methadone became commonly used. There was really nothing else for you to do or any place for you to go. And this was their whole thing, is that they basically felt that they were there for the preventative custody and remedial care of individuals acquiring a sedative dependence for habit-forming narcotic drugs. It was just this general, if you have an addiction to something, you can go to the narcotic farm. And they had this theory, which was I think widely thought of, is that if they put you in this natural environment out on a farm, out in the clean air, that you would find a way to beat your disease and you would be cured. And so they really felt that they put these in places where they were far from anything. They were really quite a ways out rurally. And really they had this whole mission. And their mission was to understand the hows and whys of why people develop drug addiction. They wanted to rehabilitate people who were addicted to drugs completely. And they were looking for a cure. They felt that they could come up with a cure. So how'd they do? Well, they didn't do so well. And in fact, they never did come up with a cure. 90% of the people who left actually relapsed, and that was very common. The hows and whys, well, they learned a lot, but there were a lot of major ethical issues and problems of some of the research that they did at the narcotic farms. Just as an aside, this would be an aside, a lot of the jazz musicians of the time were actually at the narcotics farm, and they would have some of the most famous jazz artists were at the narcotic farm in Kentucky and frequently put on lots of different concerts. And actually, Dr. Resnikoff did a podcast with us and talked about that. So it's really kind of interesting how many musicians and artists were at this place. And so what went on there? Well, they did a lot of treatment model exploration. They were looking for that recipe, if you will, of how we can help people and patients, how can we help them beat this disease? And some of the research they did, their addiction research, was done, and in quotes I put this, volunteers, right? They were inmates or residents, and they would kind of volunteer for some of the studies that were going on. And the reality of it is that even NIDA to this day, the National Institute of Drug Abuse, basically says that they did do a lot of things that contributed to the treatment and really what's gone on with addiction even till now. And this is some of the discoveries of the Addiction Research Center. They were actually advanced the use of methadone greatly. They experimented a lot with methadone, which evolved into the methadone programs that we know today. They did a lot on explaining why people relapsed. And they also recognized that there were other drugs that caused dependence. It wasn't just morphine. There were other drugs that, like cocaine and other things, that would cause it. And they discovered the opioid receptors, and they recognized the significance of these receptors, which up until that time, people had not. But I think probably foremost, the thing that they did for the addiction world was really they were the first group that defined addiction as a chronic relapsing disease. They were the first people that actually came out with that. So some of the things they did, these ethical things where they were giving their volunteers some of their choice of the drugs they wanted to be in these studies. Some of the things they did and the way they coerced people to be in the studies was potentially not the best, but they did at least come up with some things that down the road became useful. So back to some of these different acts, and this is one of the first ones that went through Congress in 1970. After the Harrison Act, as you can imagine, it was 40 some years before anything else was really done decisively. And in 1929, again, the narcotic farms came about, but there was a big gap during that time where not much legislatively went on. But what happened in 1970, and I was not practicing at that time, just so you know, I was not doing that, too young, but they came out with really requiring providers to register, okay? If they were prescribing any controlled substances at that point, you actually had to register with the Bureau of Narcotics. And later, of course, this became the DEA. And this kind of laid that framework for methadone regulation. And really a lot of what went on with developing the methadone clinics started with this first step. 4 years later, methadone actually became recognized as that treatment for opioid use disorder. And of course, the DEA required registration. And of course, in 1974, they came up with all the guidelines, which many today still stand pretty strong. And I think the methadone clinics are one of the very restrictive treatment centers that you're going to have. That they're very rule orientated how those run. And so then really there was a drought again from 1974 until about 2000. And many of you will recall the DATA Act, the Drug Addiction Treatment Act. And this is where the data waiver came from. This is where they basically said, if you're going to be prescribing buprenorphine or Suboxone, you need to have a special little course, an 8-hour course. And if you're, actually at that point, still nurse practitioners and PAs were not allowed to prescribe this. So this was just for physicians in 2000. And it really wasn't until 2016 that they added that, the CARA Act, Comprehensive Addiction Recovery Act, where they added the PAs and the nurse practitioners to the prescribing, which, as we all know, probably did the most for access to care and the ability, especially in rural areas, to get this. So that was really a critical thing in 2016 that helped us with the access. And the last thing really just happened here just a few years ago. And this was the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment for Patients in Communities Act. They should have probably come up with something a little shorter. But in 2018, this was the one that added Medicare so that people on Medicare could go to the methadone clinics. And I believe even buprenorphine at that time was difficult to get cleared by Medicare. When we started doing this, we had some patients who were a little bit on the older side. But it also was the one that took away that limit. It really took away that limit of the 30 patients, to that. When you start getting your waiver, you can only prescribe to 30 patients the first year. Now there were some ways to get around that, especially in areas where there was not access to care. So all in all, these are kinds of the things that went on that kind of led up to the methadone and then finally Suboxone in 2002. I can't move. So let's talk about the different treatment options and just a little bit more information on these things so that you're well-rounded, like you went to a liberal arts college. Here we want everybody well-rounded. Methadone was actually discovered first in Germany. And in 1939, this was a pain medication at the time. And I don't think that they really understood all the nuances of methadone at that time, but we'll talk about some of the things that make methadone a little bit more challenging and problematic. It was used in the US in the 50s again, and there was some work done on this at the narcotic clinics looking at, narcotic farms, looking at this for heroin detox and eventually heroin treatment. But this was not approved for addiction, again, remember, until 1972. So keep in mind that it was used a bit off-label and probably a little bit off to the side during the 50s, and it could only be used for detox historically until that time. One of the problems with methadone is it's different from other opiates. And I think the takeaway is really that it's just a different kind of cat. And one of the things, if we think about methadone that I actually forgot to list on this slide, is the fact that as we increase its dose, it has exponential effects. So 20 milligrams, if you double to 40 milligrams, isn't double the effect, it's often 4 times the effect. And so we always have to think about methadone as having an exponential, effect as you increase the doses. And one of the very interesting things about methadone is that people generally don't develop tolerance to this. It's one of the few opioids, full agonists, where if a patient reaches a stable dose, if we think about patients that are in a methadone clinic, and if you get to a stable dose, which in many of these cases will be 60 or 80 milligrams, the pain will be controlled and the cravings will subside, but you're not going to have to increase that dose because patients aren't going to suddenly come back and say it's not working for the pain anymore. It's very steady, and there's a lot of theory as to why it's different than the other opioids. Some think it's the fact that it's got some effect on the MDMA system, but nobody really knows exactly why we develop this lack, or there's this lack of building tolerance. So understand that that's different. That's different than the other opioids. And it's also different in a couple other ways. Methadone actually, at a stable dose, really only binds to about 30% of the mu receptors. And if you think about Suboxone, as you increase the dose, even at a max dose of maybe 20 or 24 milligrams, you might have 60 to 70% of the mu receptors covered. Methadone typically is about 30%. And the theory, of course, is that the 70% is left to function normally. And so patients will still have need some pain regulation. They'll still feel some pleasure and reward because not all these mu receptors are covered. And it's got a very long half-life. So often it's felt that the withdrawal can be less severe because in a way, if we think of an SSRI that's kind of self-tapering like Prozac because it's so long-acting, typically patients with methadone, because it's so slow to go out of your system, frequently they don't have as bad a withdrawal. The funny thing is, I mean, historically, I think my experience has been that these people tend to be pretty sick, but at the lower doses, they seem to do much better. What's the methadone dosing and schedule? Well, generally, when they're doing this in a methadone clinic, they're generally starting between 5 and 10 milligrams per day. Because of the long half-life, they don't increase that dose for 3 to 5 days. And unlike what we do with buprenorphine, there's really an ability for you to check serum levels so that you kind of have an idea where you're at. Less than 200 nanograms per milliliter is kind of considered subtherapeutic. And so typically when they're checking levels, they're trying to find people in that 300 range or in between 200 and 300. But everybody clearly is a little bit different on how they metabolize it. But it is something that can be dosed depending on how they are as far as levels. Side effects are the problem. And those of us who've dealt with methadone patients who are being switched sometimes for different reasons, often they're being switched because of some of the side effects that they've been having. And it's important to understand that there's a disproportionate risk of overdose and death with patients on methadone, whether it's prescribed or not prescribed. If you look at the total number of deaths from methadone, it's much higher than a similar number of prescriptions for any other opioid. And again, that long half-life and sometimes the issues with patients not having tolerance when they take it can really be an issue. But its other side effects are really fairly minor as far as physical side effects, the nausea, the constipation, insomnia, all of those things. But the big problem, of course, you see in the right lower corner, and that is the issue. It's torsades. And, it's this QT prolongation that we can see often these fatal cardiac rhythms. Anytime you mix methadone with other drugs that may affect the EKG, really this is the risk. And sometimes if patients are using this that they're buying on the street, they could be on medications and have really no idea that it's going to interact in this type of way. There's a lot of respiratory depression with methadone. That's probably the biggest problem, is that it's a pretty significant issue from that standpoint, okay? This is what I find very interesting, because despite all of these things and some of the problems that we see with methadone, there's really never been a significant difference in mortality between buprenorphine and methadone. And I think that you have to understand, too, that this is prescribed, okay? Clearly on the street and people that are buying methadone have a much higher risk. And I think that as more data comes out, I think we're going to find that the buprenorphine is going to be probably still the safest of the two. How about cost? Well, methadone, you're going to a methadone clinic, and these are federally funded and managed type things, right? They have a lot of rules, and they have to be there every so often. A lot of these patients will be going every day. As time goes on, maybe a little less often. But the cost really of providing methadone for a patient is roughly $6,000 to $7,000 a year for each patient, roughly. I think it'd be interesting to see how all of these things compare. How about success? Well, there's been some studies that have been done in the last 5 years that have shown that if you look at 6 months, roughly you're getting 70 to 74% retention in treatment. Suboxone is pretty much in that same grouping, maybe a little bit less. But most of the studies show that the higher the dose that the patient's on, the more likely that they have retention. And remember that one of the problems with methadone as compared to Suboxone or buprenorphine is really that if I'm taking a full agonist like methadone, I can take another agonist on top of that and get some of the problems. If you look at some of the other things we're going to talk about, you can't get additive effects of what the MAT is as compared to methadone. Methadone, it's additive if you take oxy on top of it. So let's switch to buprenorphine, and then of course, you've got buprenorphine with naloxone. Okay, I like Katie put these on my slide. It's the 1960s. It was discovered, but FDA didn't approve it till 2002, and I guess that's why we have an old an old radio, and then looks like an old iPod or something. I don't know what those are.
That's a sweet iPod.
That's a sweet iPod.
Like that.
Yeah, I did not. But again, FDA approval in 2002, and that was the first year it was used in Minnesota as well. Actually, the first doctor to ever do it here, Dr. Greg Amer, some of you may know him, was the first prescriber of buprenorphine in Minnesota. And buprenorphine is different from other opioids in the following ways. Again, in the older literature, you'll see buprenorphine listed as an agonist, but it's clearly a partial agonist. And so that really separates it from a lot of the other different drugs. It's not activating. And if we think about when things attach to the mu receptor, they activate that system. And really the buprenorphine does not do that. Bup has a much less effect as far as activation. But remember, it has a very high affinity for the mu receptor. So it will preferentially grab onto that mu receptor and it will push things off. It will push oxycodone off. It will push morphine off. It is much stronger attachment to those mu receptors. But nicely, it has a very low, it's very low as far as it's causing respiratory depression. It does have that ceiling effect. So once we get to 24, 28, 30 milligrams, we're not going to get much more effect from it. And in fact, you go much above that and you're really not going to have any worsening effect. So ceiling effect is really a key, but I think remembering how it acts on the mu receptor is very important as you prescribe it. Many of you are familiar with the dosing schedules. Again, dosing ranges probably right around 8 to 24 milligrams. Most of us will dose this twice a day. I think you can dose it once a day. In the jails, it would be once a day typically. Sometimes we will increase the dosing of this if we're using it for dual purposes. For instance, because
Increasing the frequency.
Increasing the frequency, yep. We'll do it more frequent because it does seem to work better for pain if it is given 3 or 4 times a day. So if you have somebody who's done it for pain and addiction, you can often do both those things.
What I would say on your side, though, is that this dosing range, that's a total daily dose.
Yep.
And then it's divided BID or TID.
So how about side effects and risk? Well, you don't want to inject this. I've talked to a patient who injected it, and it did not go well. The patient had been taking some opioids on the street, thought she'd get a little better effect from injecting it, didn't realize it had naloxone in it, thought she had Subutex, and she went into immediate withdrawal, was in the hospital for a couple of days. So remember that the naloxone is in there so that it can't be injected. Orally, it is broken up very quickly as it goes down the GI tract. So the naloxone does not work when you're taking this orally. One of the other side effects, obviously we see the same things with any opioid. You get that opioid nausea, or you get the nausea, the vomiting, you get abdominal pain. Those are fairly common, but really no severe side effects like methadone. One of the things we've seen lately, and we're actually going to be talking about this on a podcast, is some of the recent reports about dental concerns. And it's interesting because when I went back and I looked back 10, 15 years, there are actually many case reports of people really just having their teeth destroyed when they started on buprenorphine. But it really, until just the last 6 months, nobody had really spent a lot of time commenting on it. I'm not sure what they're going to do about that, but clearly people who are taking this sublingually are having issues with what's in it with their teeth. So keep that in mind if you have patients with troubles. What's the cost of bup? Well, you're probably looking at $4,000 to $5,000 a year. That's depending on how often you're seeing them. A lot of our patients that we see every other month when they've been stable for years, I suspect this number is probably half. So it can be relatively cost effective. Success, well, I think, a lot of the older studies showed, better retention with methadone. Some of the newer studies show that it's really pretty close. And I think in a well-run program, you probably get the same retention in that 60 to 65% range that we would see with methadone clinics as well. Again, remember, some of what makes buprenorphine successful is really having that team, and we've always kind of been big on, really wrapping around that patient and getting them in the program. So let's talk about naltrexone, because I think naltrexone is the one that is, it's been around for a while. It's been around orally for a long time. It was one that was tried a lot for opioids early on, but not so successful. This came about in 1963. It was actually developed at Endo Laboratories, and that actually ended up being bought by DuPont. But after it was discovered, really they didn't do much with it. And it really wasn't until the 70s when Congress started passing some of these different different legislation that there became renewed interest in it. And it really was because what the government was pushing for is, are there things that we can give to people that are not an opioid, that they're not an opioid or a partial opioid that patients won't become addicted to. At the time, of course, methadone was the only thing that was really approved treatment. So we had naltrexone sitting on the sideline looking for a way to be used. And it was really the fact that it had no side effects or really minimal complications that really brought it back to the forefront. It's not sedating. It's, again, not addictive. There's no fatal side effects like you see with methadone. And it's different, right? It's different in that it's a complete antagonist. So in 1974, they did a number of studies so that they could get FDA approval. And the studies were very promising if you took the medicine. And for those of you who have prescribed it orally for instance, alcohol use disorder, it works great when patients take it. And when we looked at the group that they did the study on, this was a group of patients with opioid use disorder. And frequently they would just not take it, and then they would take an opioid. And so there was a significant amount of noncompliance, a lot of relapse. And the FDA actually didn't approve it until 1984, but actually in the labeling did spend some time talking about how the compliance really limited its success. And I think that when you get some of the patients that we see out from an alcohol standpoint, it works really pretty well, less so in the patients that we see with opioid use disorder. So along came the injectable Vivitrol. Now, obviously, compliance is a lot better. You only got to show up once a month. And so this actually got approved for alcohol use disorder in 2006, and I think really worked well. And I think that, again, I've had nothing but good luck with naltrexone orally. But from opioid use disorder, it did not get its FDA approval until 2010. And again, some troubles with it. And we'll talk about why it's usually not your first choice, but it has its place, especially in people who have dual diagnosis. And by dual diagnosis, I mean alcohol use disorder and opioid use disorder. So when we look, again, this is a full antagonist. That was the one mistake I found in the slide deck. It's actually a full antagonist, and clearly has a competitive binding with the mu receptors with other opioids. But it's strongly attached, and so it's got a high affinity. So once it attaches, it's pretty difficult to push off. You can, but it's difficult. So what are the advantages of that injectable naltrexone? Well, one of them is really that there's no first pass liver metabolism. If you look at the oral dosing, so much of that is gone after the first time it passes through the liver. But when you inject it, it's a whole different ballgame. If you look at the total monthly dose, this 380 milligram injectable, and if you're taking 50 milligrams a day, that's 1,500 milligrams orally. So it's roughly a fifth the dose. So from a side effect standpoint, much less. So again, compliance is better. And so I think from that standpoint, that's a good thing. So some of the other advantages you can treat both alcohol use disorder and opioid use disorder. So from a standpoint of buprenorphine or methadone, you don't see a great improvement in their alcohol use disorder. In fact, I've had patients who on Suboxone developed alcohol use disorders. And so that is clearly one of the nice parts about Vivitrol. Compliance is obviously better if they show up for the shot, but it's clearly way better than people taking oral meds. And again, with naltrexone, it's one of the few things that we can start while people are using. So people can be drinking alcohol and start on naltrexone. And even in those instances, it's been shown to decrease binge drinking and overall alcohol intake. So,
but it cannot be started for opioids while they're using opioids.
Correct. From an opioid use disorder, you can't just do it. And we're going to talk about that. So these are the disadvantages of injectable naltrexone. Yeah. And so pain control in the event of a significant injury. Well, this is the big problem. And if you get in a big accident the day after you get your Vivitrol injection, you've got some problems, because it's going to be very hard to control your pain, if not impossible, and possibly for a number of weeks. Neither form of the naltrexone induces any tolerance, and that's an issue, because if you don't show up for your injection on day 30 and you go out and you use something like heroin, you're going to overdose, because you have not got the tolerance you'd have if you were on bupe or if you were on methadone. I have had a patient who did that. The minute he got a shot of it, injection of it when he left prison, and the minute he knew it wore off, he used heroin, and his sister found him down in a bedroom. And had she not, he'd be dead today. So it really is a big issue. The biggest problem in my mind is actually the patient has to go through withdrawal prior to starting. And this could be, quite a few days that you've got to go through the entire withdrawal with kind of adjunct medicines and then start that. And that's a problem. I'll show you some of the statistics surrounding that. And obviously cost. Cost is a big barrier. It's about as expensive as the Sublocade. So you're talking anywhere from $1,200 to $1,500 a month. So it is expensive. How is it dosed? Again, orally, 25 to 50 milligrams a day, typically given at the time that the patient would normally be drinking the most. So if they're an evening drinker, you give it at supper. Otherwise, the injectable, again, $380 a month. And often we're having to give a little bit extra the last 4 or 5 days orally, because it does wear off at about day 23, 24. Side effects, really nothing severe. I mean, from this standpoint, most people do not have big problems. Maybe a little nausea and vomiting, headache, but nothing severe. We don't have any of the QT issues of methadone, overdose issues. You just don't have that while you're on it. But again, the risks. The biggest one is precipitated withdrawal. You get a shot of naltrexone and you weren't quite telling the truth and you've been using opioids, you're going to be very ill. Or if you get it too early on when you're in withdrawal, you are going to get very ill. But again, no addiction risk. And again, the liver toxicity is only related to the oral formulation and not the injectable. Cost, again, we talked about, you're talking almost $1,400 per month. And if you look at the yearly cost, this is the one that's much more expensive, roughly that $14,000 a year per patient. So again, very similar to the injectable bupe. But the oral preparations are very cheap. And when we have alcohol use disorder patients, they do well on relatively little money. So this is the big issue that we're going to talk about with the naltrexone. And to me, this has always been the concern, is I've got to make somebody go through withdrawal to get them on Vivitrol. And this is just one study that showed that 28% of patients did not finish their induction period. The induction period being the time from they stopped their opioid until they could get their first shot of Vivitrol, which was 5 to 7 to 10 days later. And if you look at the comparison, buprenorphine, only 6% don't make it through their induction and go back to their opioids. So a pretty significant difference. Once you get the patients on naltrexone, bupe and naltrexone are very similar as far as their effectiveness. It's getting them through that first days, and I don't think there's any big tricks to get them through. We have all these different medicines, but the reality is it's going through withdrawal, especially now with fentanyl, is really pretty tough. How's its success? Well, as far as drug treatment, non-fatal and fatal overdoses, pretty similar in both groups when they're on the drug. Okay, so when they're actually in the program and they've made it through the induction period, those people do pretty similar. Again, so many of these people relapse during induction that that's my biggest concern, is trying to get them through that. And then again, that overdose risk if they stop. So we're just about to 1 o'clock. I know there's a few questions. Just as a summary, again, remember each method has its advantages and disadvantages. We have to pick and choose for each patient. We can't say one is always our first choice. It's got to be what's best for the patient. I can certainly, even though I'm not a big Vivitrol fan, there are patients that I think it's appropriate for. And I think that we need to look at the rest of their health, the medications, all these different things. So that's really it. Heather, is there a few questions? We're going to pull those up real quickly.
There's the poem.
Oh, did you want to
No, they can see it.
Oh, can you see the poll? We'll let people do the poll real quickly first. So if you're prescribing, please just let us know here. We're trying to see who's prescribing on this group. And we'll share that, maybe. So we only have a few people that are prescribing currently.
Okay, one thing I want to add though with this, and if you can't hear me, let me know, because again, our microphone is weird today. Is you need to remember that even if you don't do all forms, Kurt mentioned that you don't just pick one and go with it. Obviously, most of us can't do methadone, but you still have to let your patient know there are other forms. So like if I'm starting a patient on Suboxone, I can't just do it without at least letting them know there were other forms. And so that is like a legal federal thing.
That's in the CARE Act.
So they need to at least be notified. Even if you don't do them, you still have to notify there are other options.
Yeah, the easy way out of that is actually in our consent. It actually lists the other options you have so that you know that those things are available. And if the patient requests that, then you just have to transfer them to a provider that does that. So
do you want to explain the purpose of the waiver? That was a question.
Yeah, and I think the purpose of the waiver, in my mind, I don't get it because the purpose of the waiver, we should be having to do something to be able to prescribe opioids, but yet there's a waiver for the thing that treats opioid addiction. But I think the waiver was more initially they felt like this was a dangerous drug and that there needed to be some documentation that people had taken some training for it. Because there are some issues with it, especially if you precipitate a withdrawal. But to be honest, I don't think the course adds a ton. I think you can learn a lot pretty quickly.
I also think it was in an effort to, there are Suboxone pill mills, actually, not like the same way that there are opioid ones, but there are places who just do it, but there's no monitoring or support services. So I don't think the waiver course changed that really, because people were going to do it if they did it. So, how about insurance coverage of all of these options? Yeah, and for the most part, the insurances and even MA now cover these things. Remember, if you're getting methadone, you're going to a methadone, an FD, federally, an OTP. So you have to go to a federally funded source, which is, there's one in Brainerd, there's one in St. Cloud, there's a number in the cities, Hennepin. They're frequently a long ways away, and those are all covered and. That's not an issue. The one that has been a problem, I think, probably more than anything, has been Sublocade and Vivitrol, sometimes requiring like prior authorizations. But they're all covered nowadays. It's clearly cheaper to have people on these than to need a heart valve from IV drug use. So I think from that standpoint, they save money. So as far as using Vivitrol, are you able to give the Vivitrol while they're actively intoxicated or actively drinking? Well, let me say this, that orally, let me back up. If you read in their inserts for oral, in fact, I've been called multiple times by pharmacists who say, do you realize this patient is drinking? They can't start the oral naltrexone. And I would say, actually, that's not true. You can actually start that while they're actively drinking. Some of the other medications we use for alcohol use disorder, you cannot, but naltrexone you can. I think you have to tell the patient, actually now I've got to the point where I just tell the patient, they may say this to you, but it's incorrect. You can start on it. It's actually safer if it's injectable because you don't affect the liver. If you've got, as much, because there's no first pass where it rips through there. So I think that, if somebody's drinking excessively, then I would be more careful. People that are drinking a little bit more than they should, again, the studies show that it will decrease their drinking by about 20 to 25%. So yeah, you can give it to them while they're actively drinking. So I would say, like if you have a person inpatient who's doing a detox, they're in to monitor for DTs or whatever, and you're worried about them when they leave the hospital or detox and drinking, it's at least something to bring up or a conversation, because at least maybe then they don't drink as much when they leave. Obviously, you're going to want to address all the other issues that factor in, but if that can at least help minimize the amount, not a bad idea.
And I think that for that combo patient that has an opioid use disorder, we just got a call about a patient who was on Suboxone but was also drinking, and whether or not they could just switch him to Vivitrol. But of course, Suboxone is very long acting, and so you have to give out that for quite a while if you're going to treat both alcohol use disorder and opioid use disorder with Vivitrol, which I think is a great way to use it. It works great.
Yeah. I think it's a lot harder, though, of course, is like you mentioned, to taper off the fentanyl. Fentanyl withdrawal is even more disgusting than heroin withdrawal. And so it's trying to get through that humanely as possible, which is like an oxymoron. But
I mean, the problem now is fentanyl, sometimes you have to give them something to get them through it. And you can't, I think waiting for them to switch them to Vivitrol is pretty tough with fentanyl. With any major dose, they'll get pretty ill. So,
and taking into consideration what they do for a living, if they're people who work in environments where they're more at risk of getting hurt or in accidents or trauma, you might not want to do that because of that risk of the pain and not being able to treat it at all.
Yeah, that's probably the biggest thing. You got somebody who's climbing, trees for a living, and you put them on Vivitrol and they fall and break their leg. It's going to be pretty tough to treat them if they're on Vivitrol.
Well, even like scheduled surgeries. If they're on Vivitrol, you're going to have to be careful and, stop it or not give the next one prior to especially a major scheduled surgery. And then, of course, they have to get completely off of the opioids after the surgery if they were put on them or whatever to get back on it. So it's a great option for the patient who doesn't necessarily take their medication every day, but I think Sublocade kind of bridges that a little bit, but the good for patients that are using alcohol and opioids.
All right.
Other questions?
Yeah. Any other questions about what we talked about? All right. Well, we'll be back in a couple of weeks. Again, slides from today's session. Again, they're chatting in where you can find those if you want to use those for anything. And we thank everybody for coming today. I hope that was useful for you. All right. Have a good week, everybody.